Because of sake of time, we'll move to the second case. Going to be presented by Dr. Wael AlKashkari, a senior interventional cardiologist in National Guard Hospital, Jeddah. Wael, please.
Assalamu alaikum. I would like to thank the organizing committee of this wonderful meeting, Dr. Fawaz al-Mitairi. Every day we see like every week, every day we see the Gulf Intervention Society going on and bringing us all the technologies and the nice presentation and the nice meeting. Thank you, Fawaz. Without further detail, my talk will be focused on BCI post-TAVR and what we know about it and the commissural alignment. I will go ahead with my case. She's a 67-year-old lady who presented to other hospital with shortness of breath and pulmonary edema. Her weight is 71 kilogram. Her height is 167 centimeter. Body surface area 1.88. She diagnosed there to have severe aortic valve stenosis. Her blood work revealed BMB of 2,400 and there mild elevation of the troponin, ECG normal sinus rhythm, and chest X-ray there was pulmonary edema. Her transthoracic echo revealed severe LVH, very small LV cavity, and ejection fraction more than 55%, aortic valve index 0.5, and mean pressure gradient 72. Coronary angiogram revealed no coronary obstructive lesion. After her team meeting in that hospital, she offered surgical aortic valve replacement, and they told her, if we're going to do aortic root enlargement, it will be 19 millimeter, and otherwise we'll go ahead, we put 17 millimeter. And as you know that either one of them for this body surface area will end up by significant mismatch, and we know the outcome of the patient mismatch, patient proceeds mismatch. She declined the surgery and she went to another hospital for another opinion, and they told her the same. She ended up by coming to our hospital with to the ER with the pulmonary edema, where she was admitted to the hospital, and we reviewed all her previous medical report, and we did our own heart team meeting, and again it was the same. Either she's gonna receive 17 millimeter device without aortic root enlargement, or if they're gonna do the aortic root enlargement will be 19 millimeter with the risk of mismatch in either way and the sequelae of the complication of the aortic root enlargement. So patient decide to go for TAVR, and then we did for her this CT, which revealed here that the diameter is very small, 16.9, and the perimeter is 17, and the area is 216 only. So that is a very small area. The lowest number is 315 have been reported, and it was in the from Japan, and the register of the Japanese group is around 360, 350. So that is a very small area. The LVOT, as you can see again, is very small. This is her LVOT, and the annulus again is very small. And the heart sinotubular junction somehow effaced. Is not that great like sinotubular junction. Very like a generous and reasonable sinus of Valsalva diameter. And the coronary ostia, it's around 13 millimeter at the left and 15 at the right. So as you can see here, it's a very small annulus. We prepared everything for complication, surgical on board, and even we prepared for ECMO and a lot of things just to make the procedure very safe. We consider, like the commissural alignment that we are practicing since the beginning of 2019, and we are doing very good with that. And we do coronary access for every single patient we do. I will not tell you that our number is very good for accessing the lift system. So all this work come of the commissioner alignment by Gilbert Tang and the group. And this is the wonderful paper of the aligned TAVR. Just I will go quickly talk about the commissioner alignment before we show you our case. In simple word, this is to do commissioner alignment. The flush board, it needs to be at 3 o'clock when you introduce the device to the patient. You're gonna know that you are doing good if you see the heart marker at the outer curve in the co-planar view or the implantation view, and you see it in the front if you go cusp overlap view. The seat tab, we'll talk about it soon, but I want, like when you, for the people who start to doing it, you can see it clearly under floor or ceiling. So we want to make sure that the commissioner of the the valve we are introducing is really fitting on the commissioner of the patient. So again, this is from Gilbert Tang work. As you can see, the heart marker, you see it as one line at the greater curvature while you are introducing. Sometimes we pull back the device and adjust it, and we introduce it again when the heart mark is not like this. So this is the classic or LAO view. You will see the heart marker at the greater curvature and the cusp overlap. That's my working view. You will see it in the middle, facing you and fast. So what I mean by commissioner alignment for the audience, that the valve you implant, the commissioner align exactly on the native valve. The C-tab, we'll talk about it now. It indicates that if it is in the 3-cusp view, in this view toward the inner curvature, this means it's aligned with the commissioner between the right and coronary cusp. So this is the commissioner, the native, and this is the C-tab of the device. So once you do this and you deploy, the access will be very easy, like not very easy, it will be easy. And this is a demonstration how we cannulate it if you have commissioner alignment. There's a lot of detail, but in the view of time, we'll just give a clue for everything. So this is our case. This is the aortic root injection. As you can see, very small annulus and sinotubular junction. And there is, this is our cusp overlap view. You see the hat here. It is toward you, it's en face. So this is very assuring that we are, our commissioner alignment so far is good. This is after deploying the device. So as you can see, we are about 2.5 millimeters below the annulus. And you always remember that 23 device we used, the skirt is around 13 millimeters. So we went down a little bit because of the coronary high was around 15 and 13 for the left. And then this is our coronary axis. Very nice and patent left main. And this is after we are adjusting our catheter. So another view, where I don't know where we stop, but this is after we finished. This is the coronary injection we did. And as you can see, the C hat clearly here toward the lesser curvature. That means that our commissioner alignment is good. And again, this is another injection here. Everything is patent. This is after the deployment. I just go back. I don't know where we stop, guys. Okay. Did you see these slides before?
Yes, we did.
We did.
Okay. Okay. So thank you very much. So the message here, surgery for such patient is the best. But as you can see, she went through 3 different surgeons. Everybody decided to put a small valve. We're going to end by with this body surface area of 1.88 with a mismatch, and the outcome is of the mismatch, as you know, that's very bad. So she offered this technology, supraannular valve, better hemodynamic, with the use of the commissural alignment that I believe strongly in it. We end up by excellent result with a good coronary, with good hemodynamic gradient, almost 4, no paravalvular leak, good coronary access, and patient is doing great. Now we are completed 1 year. She maintained her gradient, and she's
Great,
doing very well.
Well, for sake of time, thank you very much. You did a great job. Very nice demonstration and explanation for commissural alignment and cusp overlap and how to access the coronaries. Very difficult anatomy, but you did it in a great job, knowing exactly what you are doing as usual. I'll just allow 2 to 3 comments, then we have to move on to the third case. So we'll start with Dr. Faisal Gofi.
Thanks, Wael, for a great case. The first comment is, this is again speaks to the concept of valve team or a heart team. CT scan TAVI should be part of any patient who's coming for aortic valve intervention, and your team should be able to provide them with multiple options, including, as you mentioned, self-expanding big valve with low gradient versus a perceval valve versus a root enlargement. The second comment, we are learning more about this commissural alignment during the SURGE TAVI trial. The IDU or the way they were positioning the valve is based on the coplanar view. We would love to see more data about structural valve deterioration and coronary access in relation to this new coronary alignment, which we all starting to do. Beautiful demonstration, and also beautiful demonstration of what type of modality we give for people with small annuli, awaiting the VIVA trial, which clearly going to answer the question of surgical AVR versus TAVI in small annuli. Great case.
Great. Dr. Fadi?
Yes, a great case. It's always a challenge in those patients. If you go with the supraannular valve, you're going to get the best hemodynamics, but with such a small sinuses, the small HCJ, when the valve is going to degenerate, you're going to have something else to consider. This lady will probably not be able to have a valve-in-valve. So this is when you're going to have to decide the age of the patient will play a role, whether you should have chosen annular valve and maybe a Portico 23 and see if this will end up, you're going to be able to have easier coronary access and maybe easier for a valve-in-valve. But here it's a very difficult decision, I think, for the hemodynamic, and hopefully it's shown that with supraannular valve maybe have the longest durability, so you may be able to survive the durability. And this is my only concern in such small anatomy when you're going to do a valve-in-valve in the future.
Can I just share an idea? Can I just share an idea to Dr. Wael? Did you ever consider doing post-TAVI CTs and reassess those techniques of commissural alignment? Is it really working fine there with the concept of the hat towards you? Did you have a follow-up CT post just to see?
Please, Wael, in less than 30-second answer.
Yeah, we are working on that, Taib, and I will invite everybody if they want to participate with us. We're gonna, like in this study, we are doing a CT for every patient just to publish our experience. I will tell you, we are doing very good so far. I'm very happy from the commissural alignment.
Great.
And I'm sure Dr. Rasha Bawardi working with us, she is she's very happy.
Excellent results. Very nice case.
Dr. Muhammad, do you have any comment?
No, excellent, Wael. You showed your skills, but my concern is the future. You made it even harder the second operation for the lady. The lady will be 5 or 7 years older, and no surgeon. That's my really concern, and I agree with Dr. Fadi. I'm just thinking, who is the surgeon who will accept her if she degenerates? What will they do? That's the issue.
Excellent.
Very difficult question.
Excellent case, excellent discussion.